I need to use a microphone, no? Hello. Oh, there you go. That works. So, hello. I don't know if it's good morning, good afternoon, whatever you had to say. Good noon. So, thanks everybody for coming. This is as a special time and lecture. So, it's a great pleasure for me to introduce Rymer, who is visiting us today from Rehab Institute of Chicago. I think most of you know or have heard of Seb. So Seb is originally from Australia, and he's a physician, although he didn't practice much medicine after doing residency and so on. He came for a postdoc here to the US many years ago. Who works, at the time he worked at the NIH, and he also is a postdoc here at Johns Hopkins. So he's been in Hopkins long ago. We were talking about Baltimore back a few decades ago. And then Seb is, I think, very known, at least because he was the engine perhaps behind all the research that was happening in Rehab Institute of Chicago. He's been the director of the sensory motor performance program, and a lot of the work that RIC has created in the space of rehabilitation, he's been behind of that. So he's a very well-known and very important character in developing a lot of the research and concepts behind rehabilitation. So for us, it's a fantastic opportunity and great pleasure to have him here today and to share some of his current work. And thank you, everybody, for attending. So.
So it's a great pleasure to be back. I've been back to Baltimore periodically, but usually for conferences and things, but to be back in the Hopkins area is especially a pleasure to see what's the same and what's different. So I want to talk a little bit today about spinal cord injury, about neuroplasticity, and as it turns out, I'm not an evolutionary biologist, but what's become apparent along the way is that actually we are tapping into some fundamental, by some of the things that I'll talk about, we are probably tapping into some fundamental characteristics of the way in which different kinds of animals protect themselves from hypoxia. And what you'll see as this evolves is that the nervous system protects itself rigorously from low levels of oxygen. And it turns out this is a theme that goes through many different animals, including mammals, and somehow or another we may potentially have found a way to tap into this in a useful way. I think I brought a pointer. Especially, these are my colleagues. Milap Sandhu is a research scientist who works along spinal cord injury. Milap Arun is a person, scientist involved in some of the early studies. The key person driving our work is Gordon Mitchell. Gordon Mitchell is a neuroscientist. He was a chair of neuroscience at the University of Wisconsin in Madison. And he just moved down to the University of Florida a year and a half ago into a department of physical therapy. And he is a megastar. So I think, oh, sorry. This big. Yeah. Is that one? So, that microphone? That's actually, I'll use that one. Okay. For Ph.D. Okay. So if you, I'm just going to step by. Yeah.
Okay. So it's hard to see around corners. That's why it was. Maybe this one is functioning. Oh, I see.
Okay, so we can mic this up to you.
Yeah.
This is for the camera. This is for the room.
All right, I want to be able to see.
So what we'll do is hook this up. Do you want to put this in the pocket? And then flip it to the side. Is that okay? Is that fine?
Can you hear me? Anyway, sorry to stop and start. A special mention about Gordon, because his basic animal work drives this story. And without having a rich catalog of how animals respond to hypoxia, especially the boundaries between safety and potential adverse effects, is key. So we are very grateful to Gordon, and he remains an active collaborator. So rehabilitation of the nervous system, paraphrased, is actually a search for neuroplasticity. And by neuroplasticity, I'm speaking in a temple of neuroplasticity, but neuroplasticity is as part of rehab is an attempt to change the structure and function of the nervous system so that it avoids the need for people to develop special compensatory responses. If you have a stroke or a spinal cord injury, you develop alternative strategies to do the work that you try to do. But neuroplasticity says maybe we can change structure and function, if not permanently, at least in a long-term way. So we know there are established and known sources. These include, of course, spontaneous recovery. You get a lot of sprouting as a result of neural damage, and we know that exercise and rehabilitation can help to sculpt those sprouts to make the neural recovery more effective. We know or believe that repetitive task performance, especially if you're paying attention and have strong cognitive engagement, helps. We know there are electrophysiological methods, including transcranial magnetic stim, coupled with peripheral nerve stimulation. If you do the timing right, you can produce a paired pulse facilitation, which can be quite striking. But then the last one option, which is basically what I want to talk about, is hypoxia. And the bottom line is it's easy. It works quite strongly. It has very strong effects. And if done appropriately, it seems to avoid any significant side effects. So it's quite promising. This is not a story about a successful, validated therapy. This is a story now about things, all being well, may turn out to be that in a few years. So. So the story begins with respiratory, with neural control of respiration. And one of the lessons that's emerged over the last couple of years is our friends and colleagues who've been studying neural control of respiration knew stuff that we didn't. And we didn't talk to them enough, because it turns out that a lot of these long-term changes that follow certain protocols of hypoxia have been known and studied for a long time. And one of the early illustrations of this is a famous animal prep. I'll explain it in a minute. Recently, Harry Goshgarian and people in Detroit have been studying but the point of this prep is that if you test the neural control of breathing in certain ways, you can show enormous resiliency and the ability to change pathways very swiftly when hypoxia is present. So this is it's called a cross-phrenic prep. It's a rat preparation in which two things are done. One is to cut the spinal cord on one side of the body in the cervical region, and that interrupts ascending projections from brainstem to phrenic nuclei on one side. So there's no discharge visible on the phrenic nerve here. On the other side, the nerve stays intact, and you can see the periodic discharge on the phrenic nerve. This is the neurogram, but this nerve is then cut so that diaphragm is not moving. If you do those things closely in time, the animal is at risk to die. I mean, it has no way to breathe. The diaphragm can't function. So what we've known for many years is that over a period of a minute or two, the animal figures out how to breathe. And the only way it can have done that is by taking what was evidently a quiescent pathway on this side on the left and using it to activate the phrenic nerve nuclei on this side of the body. And this happens within a very short period of time, a minute or two, so there's not time for any radical restructuring of neural connectivity. This has to be facilitation of existing pathways. This pathway was there before. Somehow it has been encouraged, augmented to put out a larger synaptic drive to the phrenic nuclei. So this is the model that sort of provoked the idea that hypoxia can change the way the nervous system functions. So, just to set the story up, if you cut phrenic nerve and cervical hemisection in animal models, hypoxia seems key driver of neuroplasticity. These effects on breathing recovery are manifested very swiftly and must be due to some type of synaptic facilitation. We believe that this infrastructure that sets up this recovery of breathing is also present not just in the respiratory system, neural control of respiration in humans, but also in limb circuitry. The same synaptic structure, the same transmitters, everything else seems to be analogous. So that's what's driving, that's the motivation behind some of these studies. And that's where we sort of didn't do our homework, because as I said, respiratory people have known this effect of hypoxia for a long time, but we didn't talk to them enough. So the message is that facilitation and plasticity induction using this AIH, which stands for acute intermittent hypoxia, is now looking as if it could be a useful intervention. I mean, I'm saying something which annoys my evolutionary biology friends. Through a fluke of evolutionary biology, this neural plasticity mechanism could be extended to other circuits. The reason it annoys them is because the separation between breathing and movement is arbitrary. In mammals, humans, we've got like separate anatomical structures and physiological control. But if you're a salamander or something living in murky water where the oxygen concentration may fluctuate and sometimes be extremely low, the act of breathing can be inseparable from the action of movement. So the distinction that we draw in ourselves is somewhat arbitrary. These rescue mechanisms are available, as I said, and they can be activated rather readily by modest levels of hypoxia. So I'm just going to review briefly some of the animal models that have driven our work in this area. As I said, a lot of it comes from breathing literature. This comes from Mitchell's group in Wisconsin some years ago, and they have developed preparations and equipment which allows them to cycle different oxygen concentrations automatically through the day. And this is an example in which a rat has had a hemisection of the spinal cord sufficient to drop its breathing. They're measuring tidal volume here, and this is baseline level before the lesion. Then they expose the animal to this 10 episodes of hypoxia per day, with each one 5 minutes long, and they do this automatically for 7 days. And over a period of time, you get this progressive increase in the ability to ventilate. So this animal is able to recover the neural control of breathing quite readily. This is a very high level of CO2 here, not normally what we would see, but the CO2 isn't mandatory to be there. But this is using an oxygen concentration of just 10.5%. That's about half of what we have in the atmosphere. and it's roughly equivalent to being on a very tall mountain. It's equivalent to Kilimanjaro. Kilimanjaro is about 19,000 feet, so you can free climb it. You don't need oxygen to do it. You know when you're working up there because you do get short of breath. But this is a relatively modest level of hypoxia, but in this case 5 minutes long. That's not what we do in man. We go much, much shorter. So this is the kind of thing you can see in the animal model. Here's an animal model in which we're recording from the phrenic nerve, and there is an exposure of hypoxia dropping down 11%, oxygen-inspired air. This, again, is relatively long periods, 5 minutes. And here is the periodic response on the neurogram of the phrenic nerve. And then over a period of time, you see this progressive, slow increase in background discharge, which is a form of long-term facilitation. And it's key that it be done intermittently. So, for example, if you drop it down for 25 minutes, you get a sustained increase during the hypoxia period, but you don't get the same augmentation in background discharge. You don't get the facilitation that seems to be important. And it is important also, apparently, that the reduction in oxygen be relatively sharp. Here's other tests now relating not to respiratory function, but to motility. It's a test of full limb function in a rat who is trained to do a ladder climbing task. This comes from Julian Moore in Canada, and his animal received a sort of baseline performance on this ladder, then has a spinal lesion in the cervical area affecting full limb function. He begins to make a lot more errors in the first few assessments, and then over a period of time, two things can happen. If it's a sham without getting hypoxia, the performance on the ladder task stays poor. If you expose the animal to hypoxia using one of those enclosures that I showed you, it gets progressively better and almost gets back to baseline. So hypoxia can help with recovery of breathing, but it can also help with locomotion. So without going into all the background details, we now know, partly because of our basic science colleagues, we know quite a lot about the different metabolic and biochemical pathways that are involved. We know that serotonin is pivotal. It has to be released early as a result of the hypoxia, and that's picked up by chemosensitive afferents. We know that the serotonin binds and gives rise to synthesis and release of BDNF, brain-derived neurotrophic factor, and then we go through a series of alternative pathways, and there are at least now 4 or 5 of them which result in facilitation at different synapses, including the motor neuron. And this sequence can be activated very swiftly within a few minutes. And we've now seen similar effects in at least 3 places. One, as I've shown you, in breathing. The second one was in the ladder locomotion. But not surprisingly now, you can guess it's also found in man. So our protocol is a little bit different than the animal model. We use 15 episodes of 9% oxygen using a special mask, which allows you to swap normoxic, room air for hypoxia. We use only 60 to 90 seconds. So, I mean, half of that time the oxygen saturation has not dropped very far, so it only starts to go down towards the 10.5% level. It drops down to about 85% towards the midpoint of this, and then it lags and comes back rather quickly, and then we alternate that with a 60-second exposure to room air, and we do 15 episodes of this over about 30 to 45 minutes, and interestingly and importantly, from both experimental standpoint and from a human health standpoint, most subjects don't know what they're breathing. The effect is so short and so mild that frequently they don't know they're breathing reduced oxygen mixtures. Some people acknowledge or complain that the pulse rate may go up a little bit, but usually they don't know. And then what we do in the earliest experiments is simply to look at a rather straightforward outcome variable, which is a test of isometric strength. This is just to back up some of the anatomical and histochemistry studies showing that you get increases in BDNF concentration after animal exposure to hypoxia, and also increased concentrations of regional serotonin as well. So this is the first series of studies we did in man some years ago, in 2012, and it had a person with, or a group of patients, I should say, with incomplete lumbar cord injuries so that they were paraplegic, and we put them in this setup. Here is the device. It's called a hypoxia generator. It's made by a company called Hypoxico. A person has got their foot in against a foot plate, and we can measure the plantar flexion torque that they are producing with the load cell. We are recording electromyogram activity from plantar flexors, and we are also doing pulse oximetry to make sure that we are tracking the level appropriately. We're also measuring blood pressure and heart rate, etc. And we can use this setup and alternate between low oxygen and normal concentration, and we can also do sham studies where the person is just getting room air all the time and doesn't know it, and we can do a series of outcome assessments, including muscle strength, and then later on walking speed, and then endurance in different studies, not all in the same one. And this is what we see. It's fairly representative. So this is baseline before we started the hypoxia. Plantar flexion torque of about 5-6 Newton meters. And background EMG is there. And then at 60 minutes, or no, 30 minutes after completing that sequence of hypoxia episodes, the force has gone up substantially, 30-40%. And then at the 60-minute mark, it's gone up even further. So we haven't got quite double, but we've got at least 40 to 50% increase in isometric torque. And we have seen this almost in everybody. It's a side topic as to why not exactly in everybody, and we don't really know that. We don't know if it's a genetic predisposition or whether there's some other factors that limit everybody's response, but it's in the vast majority. We see it in 60-70% of our patients with incomplete paraplegia that they will respond to hypoxia. So this shows you difference between sham, who does nothing, a population, and then different points in time following this sequence. So it's very striking. It's very powerful, and the use of the hypoxia protocol is very easy. It may be deceptively easy because we want to make sure that we are covering potential adverse events, etc. But it's very attractive for all these reasons, and it happens so fast. Those of you who are working clinically, is that a question? No. Huh?
How long it lasts?
Oh, well, I'll show you an example of that in a little while. We don't know exactly in the legs how long it lasts, but we have got good data on the hands and arms. So, for those of you doing therapy, to get 40 to 50% increase in strength alone, you'd be training for months, literally. And sometimes you'd never get there in somebody with a spinal cord injury. So to have a technique which is giving you that rapid a change in voluntary force is very promising. Now, we all know in rehabilitation that the intervention needs ideally a drug, or in this case, hypoxia, ideally will work best if it's coupled with training of other kinds. So this example where we've trained people with overground walking, and I won't show you all the data, but this is a 10-meter walk test. So if you're doing better in this study, the time in the 10-meter walk is going to go down. So here we are looking at, after a period of overground training, where we've combined the hypoxia and walking, and then looked at the effect over time, over several weeks, on the speed of walking, which is what the 10-meter test. And you can see if you get the hypoxia, some people bounce around, but basically the trend is towards more rapid walking. If you give just people sham where they don't get hypoxia, it doesn't have a systematic. There's one person who gets very much better, but mostly people do not. So the effect of hypoxia seems also to be present following a period of training, in this case, of locomotor training. So there are now quite a few studies. You always worry that this is something unique to your place, your methods, your patient populations. And there are now actually 6 studies. The last one is, so this was the first one. We had another one done combined with colleagues at Emory, and showed more or less the same thing. A resident actually at RSC did a nice study looking at the effects of anti-inflammatory agent with ibuprofen. That was a different story, but along the way she also verified that this protocol produced sustained increases in ankle torque. And we've had a colleague, one of the physician in Chile, did the tough work of showing that there was no associated, at least short-term changes in cognition, or in this case, word retrieval. So far, it's pretty safe. So, this is looking a bit more promising. Other people are seeing it, and the effects are broadly comparable. So the next question is, well, something special about the legs, or can it also be seen in the arms, which you'd expect? So we tried now several studies, not yet published, on upper extremity. So we've done incomplete cervical injury, so quadriplegia, but with some use of the hands, Asia CD classification. So we again do a preliminary evaluation. We expose people to that similar protocol of intermittent hypoxia, and we then do a series of evaluations going afterwards, and we do, at this point, grip strength, which is the easiest one to do, but we also do pinch strength, lateral pinch. We do other measures of coordination, including box and block, and 9-hole peg test as well. And I won't show you all of that. But this is where the duration of the effect is now something we can start to comment on. So here we're looking at somebody classified as between C4, C7, 13 years after the injury. And here we're tracking grip strength every hour or two following the exposure to the hypoxia. And you can see sham, which is basically breathing room air without knowing it, doesn't change over that period. And the grip strength in the hypoxia, this is one person, changes substantially, roughly the same as what we saw in the legs. But there's some interesting thing now about time course. We brought the person back the next day, 24 hours later, and it's still way different. And that's been true now for a substantial population. So this is both arms of a group of 9 or 10 patients with a cervical incomplete injury, and this is the mean values, again taken over time, also going out to 24 hours. So you'll see the sham people didn't change much. In fact, they went down a bit, and I think that may be fatigue, most likely. Whereas the hypoxia showed a sustained increase. The mean value is not quite as large. It's maybe 20, 25%, but it's clear. And these are obviously very different populations. So, yes, the arms and hands appear to show the same benefit. So, because the arms and hands were a little bit different, and because there is, I think, a little bit of skill, even though a grip test is not very difficult, you have to have some coordination in the wrist and hand to be able to do it properly. We thought it might be useful. Yes?
Can you clarify what's special about the protocol versus something like intermittent holding your breath, for example?
I tried it and it doesn't work. You can't get there. Maybe I don't have the stamina anymore to hold on for long enough, but it'd be nice if you could, and you could prepare. I'll come back to that in a minute. But so this is now a test of proximal muscles to see if we could start to understand a bit better what was going on, although I have not broken that down to any extent here, but this is a test of biceps, and we're now using high-density grid EMG recordings to record over medial, long and short head of biceps. And there's a load cell now, so we're measuring elbow flexion torque quite precisely. So here is the map of the biceps, color-coded for intensity on the left, and this is sort of background. This is now max at 30 minutes after, and then high-intensity activation later. Now, there is actually some force traces in here. It's hard to see, but they're up above 60 Newton, which is not that high. But this indirectly addresses a question, well, how do you know, Dr. Rymer, that this isn't the muscle changing alone, but the neural signal as reflected in the electromyogram is also going up. So there's at least a strong muscle, at least neural component. There remains a possibility that there's also a muscle contribution to this, which if I have time I'll chat about in a minute. But the levels of torque increase at the elbow were much closer to what we saw at the ankle. So there may be something special about large muscles with a lot of slow twitch fibers in them. So anyway, we see both of these effects in hypoxia effects in both upper and lower extremity. So to sort of parallel what we did with training in the lower extremity, we started to train people, this is ongoing, using a Mayo Spring. A Mayo Spring, for most of you, it's not a robot, it's a spring-mounted device which allows somebody with upper extremity impairment to play computer games. It supports the weight of the arm. It has sensors at different joints, including sensors linked to grip strength. And it's almost certainly not better than an expert therapist, but it's a good way for us to quantify exactly what the person was doing, so we can look at repetitions, we can look at errors, and we can also change the level of weight support that the person has to provide. So it gives us a controlled environment, and in early results, as we might expect, the combination of upper limb training with acute intermittent hypoxia so far is significantly better than sham plus upper limb training. So the message hopefully is starting to convince people that this may be promising. So this is kind of what we think now, that acute intermittent hypoxia provides, I think, an extraordinary opportunity to look at a new type of therapy for incomplete spinal cord injury. And that's because there is no therapy currently available that comes even close to generating this change in muscle strength in such a short period of time. Rather importantly, AIH is rather simple to implement, has relatively low cost. One of these hypoxia machines is about $4,000. It does not yet include control of CO2 concentration, which we should probably do. So one of the things that probably needs to happen if this is to find widespread use is that we need a bit more sensors and other control mechanisms inside the machine, so it may turn out to be a bit more than 4,000, but it's not an expensive machine. It's not a Locomite. A Locomite costs $350,000. So this is somewhere probably around between 5 and 10. And the whole issue now is that, well, does it last long enough to be useful? And most of all, is it safe? So the safety issue is ongoing. So far, it's hard to prove a negative. Not seeing a problem is reassuring, but you don't know if you just keep going another week or month or something that you wouldn't see some kind of adverse effect. So that's not something that one can answer readily. It has to be accumulated painstakingly over time. So one thing I mentioned just now, we say it's nerve, meaning CNS, but we cannot say that some of this improvement in strength is not due to muscle. And there are a number of athletic training protocols around the world where people use roughly similar protocols and do change muscle strength. This is not the same, however, as training at altitude. Training at altitude, you have to be there for a long time, and it uses different mechanisms than what we see. But there may be some protocols in intact people that have emulated this in the past. This is not what most exercise scientists tell you about when they're training their athletes. They tend to use much more prolonged exposure to hypoxia than we have. So there's something special about the short bursts, which seems to be important, and there's relatively little literature in intact subjects on that story. In fact, we're looking at that now. We sort of went backwards. We started on spinal cord injury, when if we'd have had our head screwed on right, we would have gone backwards and done it in intact persons. Risk factors, we know that hypoxia can produce endothelial adverse effects, can promote neural inflammation if it's severe and long enough. We do not know yet how to optimize the hypoxia dosage. Right now we pretend that humans are slightly larger rats. We're following exactly the rat protocol, and it's proved to be safe and effective. We don't know how to combine the training with hypoxia. Fortunately, the animal model promoted the view, especially again from the respiratory literature, that there was a period where things had to gel 30 to 60 minutes before the training for certainly for breathing was useful, and also in the rat working on a treadmill or something. So we have a period in which we can finish the hypoxia and then start some kind of additional training. But we don't know if that's optimal. As I said, we're following the rat. We do not yet know, although starting to get a better idea about time to peak and the forgetting curve. If you think about hypoxia as a medicine, as a pill, you would look at dose-response curves, you would look at how long it takes to reach peak value, and you would track how long it takes to decay, because that will then give you some hint about how to stack it in time. And the nice thing about hypoxia is it's relatively easy to do that, much easier than to do that with most physical therapy protocols. We do not know what the dose-response curve is for most PT or OT interventions. This is a lot easier to do, and we are doing it right now. And also, as I said, we copy the rat, and it has proved to be a safe base to use to design the protocols, but it may not be optimal. I mean, you know, we may do better with longer or deeper exposures than we're currently using. Okay, so just to sum up, that's kind of where we are. It's work in progress, and this is some of the funding sources that we use to support the work. So I welcome comments and criticisms, etc. Thank you. Yes, sure. I don't know if it's working. Yeah.
I'll start with a quick question. So, do you think, I mean, I have a few, but maybe a couple. So, one is any theory or knowledge about where this is happening. Is it at spinal cord level, or is it more of upstairs, the kind of brain mechanisms that are engaged? And the other question that I have is pure strength changes versus is also, do you see any evidence or behavioral evidence of control, dexterity, for instance?
So most of the basic work has been done in spinal cord, and it started with breathing, and we are sort of replicating the breathing work to show similar effects in other spinal systems, including full limb control in the rat for that ladder climbing task, etc. So it is affecting serotonin, BDNF in the spinal cord at least. There is no reason that it should not also be working in cortex. But I don't know quite yet how to track that. The problem one of the reasons we started to do pinch strength as well as 9-hole peg and box and block was to see if there was some demonstrable change in coordination. But the problem with that is you have to be able to extract what was coming from strength alone. If you get stronger, you get better at many of these tests. And we need some other test which can separate, at least to some extent, the skill and coordination from the strength. I think it can be done, but we don't know the answer yet. So we could just be seeing strength-mediated effects. Yeah.
I'd like to hear some of your comments about the possible application for this.
My hearing's not great, so can I come?
I'd like to hear some of your comments about the effects of this treatment on the developing brain, whether or not you have any data about the effects on normal plasticity that occurs in a immature brain. Being a pediatric rehab doctor, I'm very interested in non-traumatic forms of spinal cord injury, such as transverse myelitis and acute flaccid myelitis, which is something that we see in kids. And so, are there applications for something like this in those kinds of situations where you're not dealing with a traumatic injury, but a more inflammatory condition?
That is a concern. There are issues both positive and not so much negative, but concerning. We have a lot of people now. I mean, Gordon, who's sort of been the centerpiece of all of this work, has had interest from people studying multiple sclerosis, and especially ALS and hereditary spastic diplegia. There are a lot of human illnesses that may also be of value. We chose spinal cord injury because they were chronic and stable, and hopefully without potential harm, in terms of cortical function. There is a serious concern about adverse effects in the developing brain. And one of our colleagues, David Gozal, who's a pediatric pulmonologist from the University of Chicago, he acts as an advisor for us. He shows us scary pictures of kids with prolonged sleep apnea. And they show significant differences in cortical thickness on MR scans, etc. And now that's severe, repetitive. I mean, I'm not a pulmonologist, but kids having repeated sleep apnea, as a result of tonsils or something, or other reasons. I mean, their depth of hypoxia can be much deeper, and the episode can be much more prolonged than what we see. So hopefully we're not in that neighborhood, but we do worry. If we do small doses repeatedly, will we start to look like sleep apnea? But that's why we're becoming experts on cognitive testing, etc. And we will do some radiologic studies. As far as other developing brain work, I don't know. There may well be, because, hypoxia in utero is a big problem, so there may be some studies there. Most of those would be sustained hypoxia. So we sort of clutch onto the idea that 90 seconds at relatively modest level is probably safe, but that has to be proven. So.
Another question.
Sure.
Have you seen differences in the effect of AIH based on time since injury?
Say that again, sorry?
Does time since injury influence the effect of AIH?
So we've only looked at chronic, and that was, again, for experimental reasons. If you use some intervention and they're too close to the time of injury, there's some hypothetical capacity to improve. So we want it really stable. But it may well work better earlier on, because I assume your ability to release BDNF and to synthesize new fibers is probably better closer to the time of injury. But we don't know. We've only stuck to relatively long-term spinal cord injury. Yes.
Have there been any studies on complete spinal cord injuries and any change in neurological function, overall neurological function?
We have not done that. Because it's been suggested that we should, because we should, if there is a region of impairment immediately adjacent to the cervical injury, for example, we can test the benefits of hypoxia by looking at, say, hand function. If someone's sitting, in that region. But we haven't done it yet. But it has been suggested as a useful test. Oh, hey.
H reflexes or M waves to see if you can isolate?
I have not yet. Monica Perez was brought to this religion by Mitchell, who's not that far away. He's in Gainesville, and I think she's been doing TMS, and I think she had something almost ready for submission. I'm not sure if it's gone in. But, I mean, I would expect to see changes commensurate with changes in strength, more or less. Maybe not linearly, especially as strength starts to climb, but we have not. I also would expect to see changes in spasticity, which will look the same. But we haven't tested that yet. But, Yes?
I'm wondering your thoughts, actually think about a patient, but also when I go to the gym, I'm seeing people are working out with a resist of their, what are your thoughts on that?
So can you repeat the question with the microphone so people can hear the back? No, I think it's working, but put it closer to...
Well, repeat the question.
Well, my question is, I have a patient I'm thinking of, but in the gym I'm seeing athletes wearing face masks that resistive, making it more difficult to breathe for part of their training program. Your thoughts?
Well, I think it would probably be equivalent to limb training with hypoxia. If you did resistive training and breathing, coupling it with hypoxia, you probably would get, increases in tidal volume, etc. But I'm not aware of any direct test of that. Yeah.
I had two questions. One was, do you suspect that perhaps with radiculopathy we may be able to see a similar effect? And then the other question that I wanted to ask was about, you focused on motor pathways, but I was curious if maybe anecdotally some of these patients had pain, for example, which is very common for spinal cord injury, if you in your lab have seen any effects of that as well.
I don't know if it would work on radiculopathy, although there are sodium channels of different kinds on nerves, and they are responsive to monoamines and neuromodulators. So, but it wouldn't have the same, and there are no synapses out there, nor much sprouting. So I think those things would not be helpful. What was the second? Sorry.
About other pathways besides, like pain.
Oh, a sense, yes.
Yeah.
We've only anecdotally. I mean, I think it's highly likely that it's happening, but...
Reduction of pain?
Well, I didn't ask for pain specifically, but we have sort of asked about sensation, but we didn't do proper control. I mean, they're in a complicated protocol, and there's, squeezing load cells and things, so it would have to be set up more carefully than we have done, but we've certainly asked about it. Thank you.
Very good.